Hello, everyone, and welcome back to another episode of the Concussion Nerds podcast. And today we are joined by a special guest, Dr. Thompson Maesaka. Thank you for being here.
Thanks for having me.
No, I'm so stoked to dig in today. You guys are going to love today's episode. We are going to be diving into headache and migraine. This is Dr. Thompson's love. This is what he loves to do. And when I talk to I think I was talking to Eric in the beginning, the group of them that have this clinic called the Neural Connection. Best name. I love it. And is it Edina? Did I just butcher it?
Nailed
Edina.
it.
Okay. Yes. In Edina, Minnesota. I said, guys, there's a group of them. They're treating everything neurological: concussion, brain injury, migraine, headache, stroke, all the things. And I said on this episode that I wanted to talk to someone to go even deeper, because you guys know me, we love depth here on the Nerds podcast. I wanted to go even deeper about headaches and migraines. And they were like, Thompson's your man. So let's learn a little bit about Thompson. So Dr. Thompson Maesaka is a neurology specialist, Minnesota native, and has his doctor of chiropractic medicine. He's received training from Northwestern Health Sciences University, completed a hybrid track, which combined over 1,000 hours of special. This is so cool. I love that chiropractic schools do this, by the way. There's my insert. Over 1,000 hours of specialized neurology training from the Carrick Institute. Additionally, he's earned his bachelor's degree in kinesiology. Hey, me too. From the University of Minnesota. He brings a unique mix of experience into his therapeutic approaches. Ultimately, he's lived through the struggles of sports-related concussions himself. And well, he readily share his experience living with a spouse suffering from migraines. Because of this, his patients will tell you he's deeply compassionate, understanding, and willing to listen to all of your concerns and advice. Dr. Maesaka is an active advocate for people with chronic neurological conditions, frequently lecturing to help spread awareness for families and individuals struggling with complex concussions. Chiefly, his life mission is to collect all the knowledge so he can give it all away to the people that need it. Thank you so much for being here.
Thank you so much for having me, Natasha. What an intro. It's usually, hey, thanks for having us on. This is Dr. Maesaka. Let's go. That was quite the red carpet. Thank you.
You're very welcome. You know, it's funny as I read that. So sport-related concussion, let's just dig into a little bit about more you first. What sports did you play?
Sure. I was actually, the sports that I primarily played were golf and swimming, which are typically not concussion heavy. The hobby of snowboarding, competitive snowboarding, was the one that ultimately ended up getting me. When I was in high school, actually got Lyme disease and Epstein-Barr within like a week of each other. And then about a month later, sustained a concussion. So all of my immune function tanked. So I was kind of dealing with this trio of Lyme, mono, and concussion symptoms for a while. So I think the process of sort of going through the system with all of those, in a weird way, prepared me to deal with these patients that are dealing with all these complex presentations. Because as you are kind of get personal experience with going from doctor to doctor and getting opinion after opinion and then trying things and then not working and then doing your own research, I think you're much more empathetic to the people sitting in front of you. And I think that's a skill I never expected those experiences to give me professionally, because, you know, you just have such a better understanding and much more patience with the people in front of you, which I think that connects you to right away when you're able to meet them on that level.
Yeah. And so, because I mean, like I said, you've had the experience of being bounced a person and being told this is how it is. There's nothing we can do. There's nothing wrong. Was it someone in like the functional neurology realm or the functional medicine space that kind of helped you start to get that step forward? Or how did you end up doing what you do today?
It was a lot of trial and error and self-research. So I had to work through the Lyme disease first, and then the mono just kind of faded away over time. The concussion symptoms they would kind of come and go. They were never really front and center until later on. I looked back and realized like maybe some of the things I struggle with are actually from that concussion, and that occurred while I was in school. So I actually used the stuff I was learning in real time to like heal myself. Then started working at a clinic I interned with, and then picked up all the skills and ultimately just kind of pieced it together and learned on my own. Which again,
good for
is
you.
an experience I never thought would be helpful. At the time, it just felt like it was just kind of a struggle. And then, you know, in hindsight, you think, yeah, that actually taught me a lot about how to apply it to other people.
Right. I always say like life is a journey. Right. And I promise you guys we're diving into migraines. This was not part of our planned talk, but you know how I roll here. So one of my least favorite sayings, and I would put money on the fact that it's one of yours as well, is when physicians or clinicians or practitioners, whatever term you want to use, tell a client that this is your new normal and this is as good as you're going to get. Right. And it's one of those things that I always say, you can just fuck right off because that's like telling you and that's telling any human being that this is who you are. You're not going to change ever.
Right.
And I'm like, we change constantly just as we age with life, with experience, with growth. I'm like, how dare you?
Right.
And so, yeah, this journey and like the experiences you had to know, like, you don't know at the time, you might be going through the shittiest experience of your life. And you're doing everything you can to survive and keep your head above water. And when you make it through, because you will make it through, then you get to have the insight of like, oh, and it gives you so much empathy and power and tool to be able to help someone else down the road.
Right. I always thought that was such a shitty way to say, I don't know what to do with you.
Yes. Oh, I always say the clinicians, some of them probably don't like me when I say it, when I teach or when I mentor. And I'm like, you need to be humble enough to acknowledge when your client has reached your ceiling, not their ceiling.
Amen.
And so
that's such a, I'm going to steal that from you. That's such a good way to
just give me credit.
Yeah. Done.
I think it's just one of those things. And it's, it's hard for people to hear that and to admit that, right?
100%.
So, oh, I'm so stoked you're here. Okay. We are going to talk about headaches and migraines. So your wife has migraines that she has challenges with. So why is it that like my love, we were just talking about this before we recorded, like my love is concussion, which migraine is kind of encompassed into that. But why is migraine and headache your like, when I was communicating with your team and they're like, Thompson's your person, like, why is that you? Like, why is this an area that you're so passionate about specifically?
Yeah, the short answer is ignorance. It's a funny answer. So my whole life, I operated under the largely shared paradigm that most of the world still adopts, which is we all get headaches. And if your headache crosses this imaginary line, there's these other terrible symptoms that come along with it. So noise sensitivity, nausea, right? So everyone's headaches could possibly, if they get bad enough, turn into a migraine. And I used that terminology my whole life. I was like, like I would be hungover in college and be like, I have a migraine. I can't study today. Like I would just use that language ubiquitously. I feel like most of the world still does. And it wasn't until I was in school going through this that the realization just hit me like a truck. And at first it was just horrible shame of, oh my God, like it's actually not that. It's actually this whole almost like the cousin of epilepsy that has this like big, huge brain explosion. And then you get a headache because of it. And when I realized that, I was like, oh my God, no wonder depression and anxiety is so rampant with this condition because the whole world mislabels you as this like, oh, I get headaches and mine aren't that bad. So yours can't possibly be that bad. And it was just this huge like retrospective shame of like, I've been part of the problem this whole time. Like, I can't believe it's so interesting. And then it was immediately followed by like, tell me more. Like, what else about this do I not know about? And that sent me down this incredibly deep rabbit hole that I'm still actively going down of what are all the nuances of this? Because it was such that specifically the thing that made it so interesting to me is it's more like a seizure than a headache. And then when you look at it that way, then it's like, oh, interesting. Okay. If these people are having a seizure, like what's causing it? And what is the reason why these people have technically the same diagnosis, but tremendously different presentations? And then that led me down this whole path. It's incredibly fascinating. I hope we get all the way down to it today of these two camps. There's these two understandings. So for those that aren't aware, the debate in migraine land has been happening since the 1840s. So they first thought it was like, they called it, I think, a brain explosion or brain seizure or something. And then about 100 years later, they thought it was the blood vessels. So the scientific understanding has just been swinging back and forth between it's a blood vessel thing and it's a nerve excitability thing. And right now, we're currently in sort of a renaissance of understanding is we're moving away from the vascular model and moving away to the neurologic model, which for us as neurologic rehab specialists is like the best thing ever because it gives us Yeah, it means there's like other things besides medications that you can do to stabilize your nervous system so it
Yes.
doesn't explode all the time. And for
Mhm.
us, that's the best. It's sort of the same renaissance that happened with concussions. Like in the 90s, it was like, all right, you hit your head and sorry, that's just kind of dead because brain tissue dies and you can't do anything. But now it's
Yeah.
like, okay, we can do a ton. It's like everything that we can do. So it
Mhm.
was that understanding in school that ultimately was like, holy crap, I'm super sorry, first of all, for everyone I ever mislabeled. And second, tell me more. I want to know everything there is to know about this. And it's so fascinating. It's
So
incredibly.
I want to give you props for a second because so often I think as especially as we get and we're learning like we go in with a frame with a mindset, right? And a train of thought and so many individuals get kind of stuck on that train of thought and we forget to be curious. And like we talked about earlier, we forget to be humble. And so just kudos to you for being that person that could recognize, well, shit, I was part of the problem. And I was perpetuating this false information and these myths and contributing to the issue to recognize that and be like, okay, I acknowledge that. I'm acknowledge it. And now I get to pivot and do something different. And I think that is such an amazing quality of a healthcare provider because you're never going to be that person that dictates your client's ceiling because of your ceiling, just because of that. So I love
Thank
that.
you. I appreciate you for saying that. Yeah, thank you. It's sometimes a big dose of humble pie is the thing that we need the most that doesn't always go down easy.
Yeah. I remember there was no, not great. I'm not tensioning yet. Not we have too much to talk about. For those listening who know me, Thompson does not know me yet. He will, but he does not know me yet. I just reined in my tangent and like that is such a huge like win for me right there. Anyways, can we go down this rabbit hole of like so you obviously were calling these migraines your hungover headaches from being a 20 some odd year old kid in university. I have no idea how old you are now, but you were calling them migraines, being a bit of a jerk about it. And I do think that there still really is a lot of confusion and lack of understanding about the difference between a headache and a migraine. So let's just start right there.
Sure. So think of it like this. A headache, usually you can pin it down to a single source, right? There's tons of different types. Cervicogenic headache that's coming from your neck in some way, shape, or form. Tension headache, your muscles are tight or you have high blood pressure and you feel like you have a headband. That's generally able to pin it to these single things. So the Dr. Harcourt from the Carrick Institute has a tremendous course on migraines, and he lays out this
Mhm.
paradigm that I thought was really instrumental in helping me understand the difference. So, the way he describes it and the way I explain it to patients is a migraine starts in this part of your brain called the hypothalamus. It's way deep in the middle of your brain. It controls things like thirst and hunger and sleep wake cycles and all that. So think of a migraine starts there, and then it basically creates a slow burning forest fire that starts in the back of your brain, which is where vision is processed, which is why some people will get these aura symptoms. They'll see these like little visual hallucinations. And then it moves throughout your entire brain from back to front. And the way that it's diagnosed is essentially any area of your brain that is previously unstable for a variety of reasons will sort of fatigue out as this forest fire goes through. So the analogy I use for people in the office is like COVID. So when COVID hit, a lot of small businesses that were barely hanging on could not survive COVID. They just didn't have any customers, so they ended up going out of business. But the businesses that had lots of money and were very stable were able to survive. So that's kind of how brain regions work when a migraine sweeps through. So if you have brain regions that are previously unstable from concussion or electrolyte deficiencies or a whole number of reasons, that's kind of how migraines are diagnosed. So in that sense, this forest fire goes through and whatever areas fail will give you symptoms. And the things that give you the most symptoms are what is diagnosed. So let's say forest fire rolls through and the main thing that goes down is the system that governs balance, your vestibular system. You get diagnosed as vestibular migraines because you get dizzy during the attack. And so that's the main difference between headache and migraine. The headache is attributed to one single source. A migraine is diagnosed and typically classified by what regions fail as this sort of little mini seizure happens. And typically, the sort of classic presentation of it, one of the key areas that goes down are these areas in your brainstem that come down and inhibit head and face pain. So in that sense, pain with migraine, because the areas that are supposed to block out pain fail, is so much more intense and just gnarly than a normal headache. So if I say, let's say I don't get migraines. So if I have a headache that's 2 out of 10, but the part of my brain that blocks out pain is good, I really only feel 2 out of 10 pain and it usually goes away. If I have a 2 out of 10 headache and the areas that block out pain just crap out, it's like a million out of 10. It feels you'll talk to anyone with migraines, they'll tell you it's just a different kind of pain. It's like so strong, you just couldn't possibly ignore it if you tried. And it's because these systems that block out pain are part of what fails when you have an attack. So that's really the core difference between headache pain and migraine pain. Migraine pain is so much more intense because the brain structures do not inhibit pain whatsoever. They fail as a result of that little forest fire.
That's a great description. Thank you for that.
Yeah.
That course, I have not done that course yet. It's on my list of
It's amazing.
the many courses that I still want to do in my career.
Highly recommend.
There's so many.
I'll send you all the notes if you want. I have them pulled up on my computer right now.
Amazing. Oh, I can't wait. Adam's amazing. True or false? You have to have pain to have a migraine.
False.
Can you elaborate on that a little bit? It's probably similar to the same answer, but
Yeah, I mean, all that means is there's sort of 3 areas in the brainstem that go down to this thing at the bottom. It's called the trigeminal cervical complex. And if those things survive the forest fire, you don't have pain. So a lot of times vestibular migraines, you don't necessarily have pain, but you just get like crazy 10 out of 10 dizziness. Vestibular migraine is specifically one of the subtypes that is not always associated with pain.
it breaks my heart. So when you think of migraine sufferers or individuals who struggle with migraine, obviously they go to their docs. They typically get referred to a neurologist. And the mainstream form of treatment is meds or Botox, or I think in our 2 countries, there's like in Canada, I don't know if the US is the same. It always starts with Botox. And then if Botox fails, then you go to something else, or then it's like the triptans. And then if that all fails and something else fails, then you get the CGRP medications. And like there is you have to fail to try the other stuff. But medication is still the frontline defense. And if people are struggling, because I see it all the time and it just makes me cry, if people are really struggling to find a medication that doesn't work for their migraines, then they feel like they're at a loss. So can you shed some light on why that's not the case? Like medication does not have to be the only way we can approach migraine.
Yeah, totally. It's one of those things that makes me really sad as well, because by the time you've failed all of those, what it does to your body is not great. I've never met somebody that's made it all the way through that gauntlet that's like, in a great mood, like, yeah, medications didn't work so well, so I'm just here looking for other stuff. They're like, it looks like they had just run a marathon in, bare feet through a burning, brush fire. They look terrible. Typically, they're in pretty rough shape. So the paradigm that we use that I think is a great analogy out there, one, because it gives all the control to you, which is huge. Second, it allows you to kind of have more than just this one thing. That's one of the saddest things about this is they fall into this belief system that, okay, this one thing, I hope this is it. This has got to be the thing. I hope this one works. And they just get into this cycle of like, I hope this next thing is the thing that cures it all. And I think breaking out of that and looking at a bigger picture and having more tools is such a beautiful paradigm shift for these people, because like I said, I'll go back to it over and over. The more autonomy you can give these people to really get them to believe in the idea that they're the ones that have the control, it can reduce the mental burden of it all. So the analogy we use is called the bucket theory. So I love this theory. It makes it resonates with patients so much. So we all have a bucket. The bucket, typically with migraine people, is very close to full. So there's some debate as to what the bucket is. I like to explain it as the autonomic nervous system. If you're not familiar, it's the balance of stress and relaxation. So if you're really stressed, the bucket's full. And if you're not stressed out at all, the bucket is empty. So my role as a clinician is to figure out, okay, is it a bucket problem? Is your bucket too full? Or is one of several faucets dripping water into the bucket? So the faucets that we look at your neck, look at your hormones, we look at your nutrition, We look at how your eyes and vestibular system function, which from a clinician standpoint is just visual vestibular function. So do they have any issues with how their eyes move? And then another thing we look at is like low level infections. So is it Lyme exposure? Is it mold exposure? Is it SIBO? So it's this collection of things. So in that sense, it's really helpful from a patient standpoint because they have this roadmap of things that they can really choose therapies for that they don't have to go to a doctor to do, which is super helpful. And then within all those things, there are several tools that are all just sort of this accumulation of things that we hope they will adopt that ultimately gives them everything they need at home. So that's usually where we start clinically, is we assess all those things and then give them a roadmap and say, okay, here's the priorities. This thing is going to give you the most relief right now. And then we work through those over time. And I haven't really run into a person that hasn't had, pretty significant relief if you get all the way through that. And it blows my mind. Imagine how much better people would be if they did all that first and then started, because I'm not saying that's going to work for everybody. Usually there's a perfect combination of that stuff and medication that will get them migraine free. I'm not demonizing medication. It's just so backwards. Like if you just started there, they would be so much healthier. And then the medications have a chance to actually work.
Thank you for that. That was fantastic. And you kind of nailed it on the head. There's never just one thing, right? And this is what when I work with and when I mentor in the persistent concussion space. So my mentorship program is called Concussion Nerds. So I mentor clinicians in teaching them how to rehab concussion. And I say, hey, when you're shifting from working with acute concussion to persistent concussion, it's a different ball game, especially when you're working with someone who they're anywhere, let's say 18 months to years out, right? I just gave a talk earlier this week to a group of realtors about the importance of optimizing brain health in a fast-paced, high-stress career and what that actually looks like and what brain health actually means and like how all these pieces. And like the classic question of, do you experience brain fog? Do you feel like your thoughts are kind of sluggish? And again, none of those people in that room had an injury, but it's kind of relating back to, did they do something earlier in life? But again, it's not just one thing. And I think so often what happens to so many individuals who are on this journey is, and they've seen 5, 10, 15, 20 different providers, tried 10 different medications, is in this place of like desperation. And hope is at some point non-existent anymore. And they're looking for that cure. They're looking for that person to fix them. And a big piece of those conversations in the beginning is there's hope. Like this doesn't have to be your life. B, it's going to take work. Now, if we I know if we had magic wands and we could be like, ding, we'd do it. We'd absolutely do it. I'd use it on myself every dang day. But that's not the way it works. And when we have been on something chronic like persistent concussion or migraine or these things, there's not just going to be one thing. And I love that you kind of do that initial piece and then help that roadmap to give them the autonomy and the control and power. Because let's face it, when someone's on a persistent journey or in a migraine journey, they feel like they have no control. And when we are constantly living in a place of uncertainty, constantly living in a place when we feel like everyone else dictates what happens next, how does that make us feel safe? Your nervous system is living in this place of sympathetic. So the fact that you start with, and I always talk about this combination of management versus treatment, and that it's not one or the other, it's the harmony of both. And I feel like that's exactly what your roadmap is doing.
Yeah, we also have this discussion almost before we even get into that about, so there's this study out there, I can dig it up for you if you like. It has to do with characteristics of events and why they're stressful. So it laid out like, okay, what are the most stressful things that can happen and why are they stressful? And two of the characteristics of the most stressful things are a sense of unpredictability and a sense that whatever happens to you is out of your control. But if you look at migraine or persistent concussion symptoms in that context, Most of these people have no idea when they're going to have an attack. They plan their entire life around trying to predict it. And if you're stuck in this medical model, sometimes you feel as if you have no control, because if the medications someone else gave you don't work, you're hopeless. You're completely out in the
Mhm.
open. So if you think about it in that context, that's why we really emphasize the point you just made, is you can reduce the burden of stress this condition has over you by taking control and helping you feel as if you are in control of it. Just by nature of how stressful that is to you, just feeling as if you have the tools within you is such a powerful way to take this incredibly stressful entity in your life and just sort of go, oh, okay, there's a lot of stuff I can do. I think to your
Mhm.
point, that's such an important paradigm shift to get them out of that. Because once they grasp it and you can really see the lights come on when they start to go, oh, okay, this is something I'm going to have to do to myself and not something you're going to do to me. That's when the game totally changes. And I know as soon as that light comes on, it's like, okay, you and I are going to we got to do this as a team. And I know that you're in the game now.
Yeah. I'm gonna layer another piece onto that because I love that. When you look at trauma and you look at how we manifest trauma, right? And Gabor Mate's definition, and when he looks at it, and the big component of it's not the event itself that is necessarily the trauma, but that piece of, do you have support to help you navigate, integrate, and move through the trauma after? And we as clinicians are a support. And so often our clients feel like they haven't been supported, that they've been gaslit. Medical trauma is a real thing. And when you layer in everything you just said, then plus having a supportive clinician who actually truly feels like a team, the fresh perspective and the hope that comes from that to then be able to go on that journey is so powerful. I feel like we could talk forever. So I'm going to shift into a little bit of a clinical mindset for a second. For the clinicians listening to the Nerds podcast right now, what would you say to them is super important if they get someone that has, like, they get a migrainer in front of them that they need to suss out, include, and look at in their assessment? Huge question that you're going to answer. You don't have to
Right.
go into super detail, but what are the things that they need to have in the forefront of their mind that they need to remember to look at?
Yeah. So go back to the bucket analogy and just start there is what I would suggest is, okay, start autonomic. Largely, if you had to lump migraine in with a specific system, I would probably put it as an autonomic condition, right? If you can balance the autonomic system ahead of time before doing any sort of rehab, you're going to get so much more mileage out of that. That's true with concussions as well, right?
Love your
Like,
answer. Yeah.
you can't really rehab a system that's totally skewed towards the sympathetic. So that's a great place to start. What I like to do ahead of time is get a sense of where their capacity for change is right off the bat. That's, I think, a variable you need to flush out before you just go, okay, take the supplement, eat this way, do these exercises. If you immediately overwhelm them, you just set them up for failure, and then you're going to set them up for long-term failure. So the thing that I like to do is just give them a few basic things, and the highest leverage items consistently across are, okay, generally address neuronal stability. So how do you do that? Supplement electrolytes. Easiest, most common low-hanging deficiency across the board. Calcium channel blockers. It's a whole class of drugs they prescribe just to prevent ions from leaking out of these people's cells. That's one of the genetic components of migraine, is they accidentally leak ions out of their cells, which narrows the membrane potential, which makes it more likely to fail as the forest fire comes through. So without even rehabbing, just increase their membrane potential by supplementing electrolytes. And that will, one, stabilize the system. So if rehab is appropriate, go for it. Two, it will tell you immediately how willing and fast they're able to implement suggestions, which from a lifestyle change standpoint, I think is huge. You can't just assume everyone is going to be super ready to change all of their habits, because ultimately it's kind of the game early on is, okay, we need to rehab some of these daily behaviors so that the rehab can do its thing. So I think I start with electrolytes. If they get that right away, cool. Okay, let's go after foods. It's a really common list of foods that trigger migraine. Surprisingly, a lot of people don't know what they are. Chocolate, alcohol, citrus fruits, fermented foods. Just give them that list. again, assess how long it takes them to implement these changes. If they're like, okay, great, I don't eat those foods anymore, done, then move to, let's say, supplementation or histamine. Shameless plug, I'm not affiliated with them at all. There's a very well-defined list of supplements that work with migraine. I used to have a little hesitation in going there because it's like, okay, I need you to take a B complex, feverfew, curcumin, fish oil, 9 different supplements, and just watch their eyes kind of glaze over and they're like, oh my gosh, it's a lot of supplements. Someone made one somewhere along the line. It's called Mighty, I think. The company is called Melina. It's just an all-in-one migraine supplement. I don't get paid for suggesting it. I just think it's such an easy all-in-one supplement. So that would be another great place to start therapeutically. And then
I know the audience is going to ask, can you send me a link for that after? And we'll just drop it in the show notes because I know I'm going to get the question of what was that supplement?
Yeah, absolutely. I believe it's called Mighty.
Okay.
It's like an all-in-one supplement that just includes everything the research says is helpful. So that's the pecking order that I go through just to summarize is electrolytes, if they're good, then supplement, if they're good with that. Since it's only one, then move to cutting out foods. It's a little bit more of a challenge for most people. Then if they can cut out foods, go into histamine. Histamine-free, low glycemic diet is sort of the big daddy of lifestyle changes. That's ultimately the most effective. Not only will the lack of histamine production reduce the intensity of pain and the pulsatile quality of the migraine itself, the stability in blood sugar, if you actually look at some of the dietary recommendations for epilepsy, that's one of the main recommendations is just stabilize your blood sugar so it's not caught in that like low sugar state. It's much more likely to trigger a seizure. Same thing with migraine. So if you can work through all of those things and gather enough rapport with the patient so that they're like, okay, everything I say now, they're on board. They've seen results with the first, they've seen results with the second. As you start to gain some traction with the patient, with the person in front of you, then rehab, one, is not only significantly more effective because their autonomic system is hopefully stable, they're nutritionally not triggering migraines with histamine and blood sugar fluctuations. Now rehab is a piece of cake. Now you can just hammer them and it actually works. I think it's especially with, we see a lot of concussions as well. And when we see concussions, it's like, all right, let's rehab this, let's go. And it's, I think, pumping the brakes and establishing that rapport and relationship first is hugely beneficial.
I love that. Thank you so much. I feel like we might just have to have you back because we could keep talking forever. If people want to connect with you, what is the best way to do that?
Yeah, shoot me an email. It's Dr. Maesaka. The last name is spelled Maesaka at theneuralconnection.com.
We will also drop that below.
Yeah, I make a lot of education content on TikTok as well. My handle is the Headache Whisperer. So I make a ton of specific to mostly migraines on there. There's a ton of free information there. And I'd be happy to answer any questions. Happy to connect.
Amazing. Thank you so much for being here. Thank you for your passion in the space and who you are as a human. Your clients are very lucky to have you on their team.
Well, thank you for putting the time and effort into this podcast. And I would say the same to you. Thank you so much for having me on.
Thank you. You don't go anywhere once we stop recording. But to everyone listening, we will be back next week. And until then, have an amazing day. That's today's episode. Thank you so much for tuning in. If you liked what you heard, give us a like, give us a share, give us a tag on Instagram, and please never hesitate to reach out. We love communicating and connecting with you. Until next week, my friends, have a marvelous day.